This
be talking
conference will
about
now be recorded.
septoplasty. So, uh, as you know, the septoplasty is a like a plastic surgery. That's where the name plastic came, and done on the septum. So, the septoplasty is a conservative procedure done to correct the septal deformity. Now, you must have read the different types of septal deformity, like a C-shaped deformity, a S-shaped deformity, a spur, caudal dislocation of a septum, etc. Now, so septoplasty is a conservative approach where you try to preserve not only the cartilaginous part but also the bony part also. So there is unnecessarily you should not remove also the bony septum. So try to preserve both the cartilaginous and the bony septum, and the main focus area will be here. The This is the caudal strut. So this is the dorsal strut, and here you have the caudal strut. So these two, the L-shaped piece of cartilage is very much essential to maintain or to give support to the cartilage. Otherwise, if you remove the dorsal strut and the caudal strut, then there will be a collapse. There will be a collapse of the cartilaginous septum. Now you can see the septum again is divided into say four parts: the columnar septum, membranous septum, cartilaginous septum, and bony septum. Now the columnar septum is formed by the medial crura of lower lateral cartilages. Then the membranous septum only has the skin lining, and then you have the septum proper, that is again comprising of cartilaginous part and the bony part. Now the cartilage is known as the quadrilateral cartilage, and here you can see the cartilage right over here and coming and sitting over the bone here, and then going posteriorly, and uh, you can see the junction between the bone and the cartilage. This is the perpendicular plate of the ethmoid, and this is the vomer bone. So you can see the cartilage is resting is very intimately related to the vomer inferiorly, and the perpendicular plate superiorly of the ethmoid. So the ethmoid and the vomer are the major contributor, and with partial as a contribution coming from the rostrum of the sphenoid and the crest of the maxilla, the crest of palatine bone, the nasal frontal spine, nasal bone. So they have a minimal contribution, and then the anterior nasal spine over here also has a contribution to the septum. Now, this is in a short regarding the septum. Now, the septoplasty, we will talk both about septoplasty and SMR. Now, septoplasty is a more conservative approach, I have already mentioned to you, and it can be done below the age of 17 years. So, the youngest recorded is around with a very successfully operated septoplasty is around 6 years of age. So, and then the pediatric septoplasty is again a different chapter altogether, because the face goes on growing till the age of 17 years. So, and then if you operate on any cartilage at the age below the 17 years, then that causes the arrest of growth of the cartilage and leading to a facial deformity also. So that is why most of us don't advocate any surgeries on septum, even though the indication is there. But unless and if you can avoid it and postpone the surgery, that is the first should be the first option. at least till the age of 16 or 17 years, till the face development gets complete. Now, these are the artery supplies. You can see the main artery comes from the spinopalatine artery. Then you have anterior and posterior ethmoidal artery. And then you can have the causal back plexus, where you can see beautiful. And here, from here, you have the greater palatine artery coming along the floor. And then you have the septal branch of superior labial artery coming from here. So they form the plexus, and this is the nerve, and this is the another this spinopalatine artery, the posterior ethmoidal, anterior ethmoidal, and then columnar artery, superior labial artery. You can see coming all the way up. So these already I have told to you. The septal spur needs little that is a shelf-like projection at the bony cartilaginous junction. So very important. You should know what is the definition of a spur. Very frequently asked question in your exam. So the caudal end of septum is projected over columella on one side due to a subluxation of septal cartilage over the anterior nasal spine and maxillary crest. So here the caudal dislocation means you can see very clearly the caudal end of the septum cartilaginous. Usually you don't see, but when you see the caudal end of the septum, then you say there is a caudal dislocation or anterior dislocation. Now here you can see this is the caudal end of the septum. Can you see? Very clear cut. You can see. You need not even, so to see that you have to raise the tip of the nose. So that is called as a tip raise test. And you can see here this is the spur, and the spur is almost going and touching the lateral wall, that is the inferior turbinate here. You can see this is the floor of the nasal cavity, and this is the cartilage over here. It is the septal cartilage, and this junction, this is the vomer bone, because it is there on the floor, more towards the floor. So this is the spur is between the cartilaginous septum and the vomer. So the patient, usually what happens, these deviated septum patients usually come with the most common complaint of nasal obstruction. Now, see, it is very important as a clinician to ask in detail about the nasal obstruction, like whether it is a static obstruction or it is a dynamic obstruction. So static means it is there and it doesn't get relieved. And even if how it gets relieved, whether it gets relieved on using some local decongestant drops, so like oxymetazoline or xylometazoline. So that also you should ask, and whether the obstruction is there only on one side or is it alternating. Now, what happens usually, the patient says sometimes that this alternating nasal obstruction is known as the nasal cycle. So you should not get confused with that. So alternating nasal obstruction usually we have, but we are not aware of it. So sometimes the patient may be aware of it. So in that case, doing a septal surgery won't really help the patient. So only when there is a clear-cut obstruction on one side, a fixed one, and just gets relieved on using oxymetazoline, or even with oxymetazoline also sometimes it doesn't get relieved, is an indication for surgery. So nasal obstruction is one. Then number two is headache. Some patients will complain of headache. Now, if I go back to the previous picture here, the septum impinging on the lateral wall can give rise to headache. So a spur impinging on the lateral wall can give rise to headache. So headache will be a part of the complaint. And then sinusitis. So if a spur is there between the say the perpendicular plate of the ethmoid and the septal cartilage, and then that impinges on the middle turbinate and pushes the turbinate still laterally, thereby uh, compromising the middle meatus, that can result in sinusitis, and then sinusitis will also lead to headache and all. So sometimes there may be a syndrome known by the name of Schluter's neuralgia. So Schluter's neuralgia is called anterior ethmoidal nerve syndrome, where the spur presses or gets impacted on the lateral wall and then causes irritation of anterior ethmoidal nerve, leading to headache. So in this condition, um, after removal of the spur, these patients will show improvement, and the headache might come down. Hmm. And then epistaxis. So epistaxis is usually also associated with spur. That is why spur is very important, because apart from nasal obstruction, which is associated with septal deformity, rest all is a headache, sinusitis, anterior ethmoidal nerve syndrome, that is Schluter's neuralgia, and epistaxis, all are due to a spur. So that is why you should remember the definition of a spur. Now coming then, once the headache, sorry, once the patient gives history of nasal obstruction, then it is then the next examination you do after asking few questions is anterior rhinoscopy. So anterior rhinoscopy examination with a thudicum nasal speculum is done, and then seeing the anterior part of the nasal cavity. Then you, from there, by inserting a thudicum speculum, you can have a good view of the septum, and you can see the deviation, the deformity, the spur, and the deformity, and then you can assess how bad is the deviation. And after the anterior rhinoscopy examination gets over, the next thing you do is you do a cold spatula test. So a cold spatula test establishes the fact that the patient is having nasal obstruction, and where you find that the mist formation on the affected side is very small, or even sometimes might be absent, and in the opposite side, the mist formation is adequate. So that establishes the what you say, the deformity or the bend. Now, next test you do is what is given here is a Cottle test. So, Cottle test is done in case of nasal obstruction due to abnormality of nasal valve. So, the very frequent question is what is a nasal valve? So, nasal valve is nothing but the narrowest part of the nasal nostril. So, you have two valves on the right and left side, and there are two valves. One is the external nasal valve and the internal nasal valve. So the external nasal valve has the three boundaries. On medially you have the columella septum, and laterally you have the lateral truss of the lower lateral cartilage and the fibro fatty tissue of the ala of the nose, and inferiorly you have is the nasal sill, that is the skin line part of the nose. So you have an external nasal valve, and then you have the internal nasal valve. The internal nasal valve again has three boundaries. Medially you have the septum. Laterally you have is the caudal end of the upper lateral cartilage. Caudal end of upper lateral cartilage and the anterior part of the inferior turbinate. And in the inferiorly you have is the floor of the nose, that is the bony part of the nose. So there are two valves, I told you, the external valve and the internal valve. So if the deformity or abnormality lies in the internal valve, then the patient will have nasal obstruction. Like if you compare the nose, it varies from person to person and even varies with the race. Now, if you see a Western Caucasian person, they have very long and thin nose. Whereas if you see a Negro person, they have platyrinia, that is a flat nose. So a person having a long and a thin nose will have a very small nasal valve, whereas a person who has a flat nose will have a wide nasal valve. So in Caucasians, it is seen that the nasal valve, the angle is around 10 to 15 degrees, around 10 to 15 degrees. So, so this, and suppose there is still narrowing of the nasal valve, then the patient develops complaint. So this narrowing may be congenital or maybe traumatic or maybe iatrogenic also. Say you have done some surgery of the nose following which the valve gets still closer, or maybe following a trauma, or maybe congenital to the person. So in those conditions where the valve is very narrow, the Cottle test will be positive. So what happens in a Cottle test and what is the dynamics behind it? Now, Cottle test is if you ask the patient to, suppose the patient is having an obstruction on the right side, you close the left nostril and ask the patient to breathe. And then the patient breathes in and then breathes out. You tell him to breathe in and breathe out, breathe in, breathe out. And then what happens? All of a sudden you pull the cheek upwards and laterally. And when you pull the cheek upwards and laterally, and then you stay the patient, continue breathing. And after say 4 or 5 breaths, you ask which was better. If the patient says, "Sir, when you have pulled the cheek, I felt much better and air entry was adequate," that means the Cottle test is positive. So positive Cottle test indicates a narrow nasal valve. So then here again, two things comes. See, there may be again a static obstruction, or there may be even a dynamic obstruction. Now I'll give you one example. Now a patient who has a very pliant alley of the nose. The alley, normally if you see the alley of the nose, if you press on the cartilage, it bounces back. But in some person, the alley is very poorly developed. And so what happens when you when the patient breathes, inspires, then there is entry of air into the nose or the nostril. And where as the nostril has a very narrow cross-sectional area, so what happens? There occurs turbulence. So this turbulence causes a drop in the pressure at that particular area, and thereby when the pressure drops, the alley comes and closes on the septum, thereby cutting off the air entry. So this is a dynamic obstruction where the lateral wall is collapsing onto the septum. Do you understand? Any doubt till now? Hello, students. Hello. Can you hear me? Hello. Hello. Can you hear me?
Yes, sir. Audible, sir.
I actually after I'm asking since last 5 minutes. One of you should answer no, whether you are able to hear or not. I have asked you minimum 5 to 7 times. Then you are responding. So are you following what I just told you? Did you follow how the Cottle test becomes positive and what is the dynamic behind the Cottle test?
Yes, sir.
Okay. So, so this is what happens when the cross-sectional area of the, particularly the valve, the internal or the external nasal valve, uh, happens to be less. So, as a surgeon, you should keep it in mind, and you should try to increase the cross-sectional area uh, of the not only the same side but also the opposite side, so that what happens ki more air enters into the opposite nostril, and thereby reducing the negative pressure on the problematic side. So this is about Cottle test, and I have already spoken about headache. So Cottle has classified septal deviation into three types. One is simple deviation. Here there is mild deviation of nasal septum and there is no nasal obstruction. Commonest condition encountered and needs no treatment. So you see, if you examine now, around 70% patient will have some amount of deviation, 60 to 70%. But they don't, all are not symptomatic. So only those who are symptomatic, you operate. Then next is the obstruction part. This is more severe deviation of septum, which may touch the lateral wall of nose, but on vasoconstriction, the turbinates shrink away from septum. Hence, surgery is not indicated even in these cases. So, but the impaction, there is marked angulation of septum with a spur which lies in contact with the lateral nasal wall. The space is not increased even on vasoconstriction. The surgery is indicated in these patients. So you can see simple deviation, obstruction, impaction. We have already talked about it. So if it is impacted, then you have to operate. So septal surgeries, submucosal resection and septoplasty. So I will discuss both of them simultaneously. Submucosal resection is more like a radical approach, and there is another thing known goes by the name of Cottle line. So Cottle line is nothing but you draw an imaginary line from the nasal process of frontal bone onto the anterior nasal spine. Nasal process of frontal bone onto the anterior maxillary spine. So if the deviation of the cartilaginous septum occurs anterior to the Cottle line, you do septoplasty, and if it is posterior to the Cottle line, you go for submucosal resection. So this is one aspect, Cottle line. Then submucosal resection is reserved above for patients above the age of 17 years. I have told you why. Then the submucosal resection, here what you do is you remove the major part of the cartilage, just leaving 1 centimeter dorsal and 1 centimeter caudal strut. So if I have a septum, here you can see. This is the caudal line which we are talking about, from the nasal process of frontal bone to the anterior maxillary spine. Here if the deviation is there, you do septoplasty. If the deviation is here, you go for a submucosal resection. So so then, submucosal resection is indicated in persons above the age of 17 years. I've already told you. Now, the incision given are two different incision. One is the Killian's incision for submucosal resection, and the Freer's incision or the hemi-transfixation incision uh, done for or given for septoplasty. So the Killian incision is given 1 centimeter cranial to the caudal end of, or behind the caudal end of the septum. Okay, so and then the Freer's incision or the transfixation incision is given on the caudal end of the septum. So this in septoplasty, the incision is the Freer's incision or the hemi transfixation incision which is given over the caudal end of septum, and in submucosal resection, it is a Killian incision given 1 centimeter behind the caudal end of the septum. So the reason why you give 1 centimeter behind the caudal end is to preserve the 1 centimeter caudal strut, which is must to maintain the uh, external or to prevent any deformity post surgery. Now, septoplasty can be combined with rhinoplasty to do a septorhinoplasty. You cannot do a combination of submucosal resection with rhinoplasty. Then septoplasty, in revision septoplasty is much easier than a revision submucosal resection, because here you have retained most of the cartilage, but in submucosal resection you have removed it. So then it doesn't. There is only a mucosal flap. The chance of tear while revision surgery is far high in a submucosal resection. Then septoplasty can be done below the age of 17 years. I've already told you. SMR you can't do it. And then the complications like say septal perforation, a septal columnar retraction, a flapping septum are solely seen in, and a supratip deformity, a saddle nose deformity are solely seen in submucosal resection. So saddle nose deformity, supratip deformity, columnar retraction, flapping septum, septal perforation are usually seen in submucosal resections. Rarely in, almost not seen in septoplasty. So these are few differences to go with, and the incision. I'll tell you, you can do it under local anesthesia in a cooperative patient, or you can use general anesthesia. And local anesthesia is same. We give Fortwin and Finargan 45 minutes before the surgery, IM, and then the patient is sedated when he or she is shifted to the OT, and then you infiltrate the nose. So the infiltration again is same, 2% xylocaine in 1 in 2 lakh adrenaline. And the infiltration, I have told you last time, it depends on the body weight, how much you infiltrate. That is, if you are using xylocaine with adrenaline, it is 7 milligram per kg in body. Now, based on that, you calculate how many ml you can infiltrate max. So you infiltrate the nose on both the side, and then you allow for 5 to 10 minutes. The infiltration does two things. One is with xylocaine, it obviously gives anesthesia. Then with adrenaline, it prevents, it decreases the bleeding. Third thing is when you infiltrate in the correct plane, it causes a hydrodissection. So the dissection is already done for you. The flaps are elevated from the uh, cartilage and bone. So very important. A good infiltration is almost like 50% of the surgery. So you should do infiltrate the correct plane. Then after 5 to 10 minutes, you go ahead with the surgery. Suppose let us say submucosal resection we are doing. You give a Killian incision that is 1 centimeter behind the caudal end septum. Then elevate the mucoperichondrial flap over the cartilage. So then you also elevate the mucoperiosteal flap on that side. Okay. Then what you do is just either little anterior, not anterior, little posterior to it, you give an incision on the cartilage. So where you have given the incision on the mucosa, just after elevating the mucosa, you will find the cartilage. So remember, the cartilage is ivory white in color. If it looks off white, means one or two layers, one layer might be still left behind. So the cartilage is ivory white in color. So till you get ivory white, no, you are when you get ivory white cartilage, you are in the correct plane. If you have not got an ivory white, then maybe still a thin layer is still persisting over the cartilage. So make sure you elevate at the correct plane to prevent bleeding. So then once you see the color, ivory white color of cartilage, you elevate, and then the mucoperichondrial flap, then the mucoperiosteal flap. Then after elevating it, what you do, just posterior to the incision, you give a very gentle incision on the cartilage, and then go to the opposite side. Go to the opposite side, elevate the mucoperichondrial flap. Okay. Then after elevating the mucoperichondrial flap, what you do is you can also elevate the mucoperiosteal flap on the opposite side. Now the septum, both the flaps are elevated on either side. Then after elevating both the flaps on either side, you take the Killian's long bladed nasal speculum. So Killian's long bladed nasal speculum, you insert it, the self-retaining one, tighten the screw, and the blades will open up, and then you have a good view, and then you can ask your assistant to just hold to the Killian's speculum. Meanwhile, you assess the deformity. So if you have decided you are going to do an SMR, directly you take a Ballinger swivel knife and you remove the deviated septum, deviated cartilaginous part, leaving the 1 centimeter dorsal and 1 centimeter caudal strip. And then whatever bony deviation are there, you remove, and that then what you do is flush the septum, clean it properly, and then close it after securing hemostasis. So it's very easy compared to septoplasty. I will not say it's totally easy, but it is compared to septoplasty. It is easy. Now, septoplasty, on the other hand, you have to retain most of the parts of the nasal septum, and still you have to correct the deformity and also see the functional aspect of the nose, that is to relieve the nasal obstruction. So here there are few techniques. One is the cutting technique. The number two is the suturing technique. And number three is the relocation technique. Okay, and number four, and forgetting, I'll tell you. So first is the cutting technique. So what happens in septoplasty, the main difference is here the mucoperichondrial flap is preserved on one side. So suppose you are having a C-shaped deviation, say to the right side. So C-shaped deviation of septum to the right. So that what happens on the left side, you have a relatively spacious nasal cavity. Relatively, not I am not saying, because there are some cases there will be compensatory hypertrophy of inferior turbinate, which you can tackle it. If you pack the nose just with 4% xylocaine and adrenaline, no, automatically the turbinate will shrink and you will get a good space to maneuver the instruments. So always remember, the incision is always given on the concave side. So concave side, why? Because the one is you have a lot of space to maneuver. The number two is the mucosa is not stretched like on the convex side, where it is stretched by the deformity. So the chance of tear is comparatively less on the concave side than on the convex side. Okay, and now what you do, the incision is at the caudal end of the septum, the hemitransfixation incision or the Freer's incision. Now the incision on this caudal end of septum depends on the deviation, amount of deviation you want to tackle. So if the deviation is very small, then you can give a small, mini hemitransfixation, or if it is of a moderate size, then you can go for the conventional hemitransfixation incision. But if it is there, some deformity is there over the near the floor of the nose, then you have to go for a extended hemitransfixation, where the incision, the curvilinear incision starting from the caudal end of septum is carried onto the what you say the floor of the nasal cavity. So particularly as per say between the vomer and the sept and the quadrilateral cartilage, you have to go for a extended hemitransfixation incision, where it comes all the way onto the floor of the. After giving the transfixation incision, then next is the elevation of septum. But anteriorly, what happens? The elevation is little tricky. Whereas in Frears, the elevation is very, if you are in the correct plane, you can elevate it very fast. But in case of caudal end of the septum, there is crisscross of fibers. So you have to have little patience, and you have to do it very slowly to prevent undue fracture of the septum. If you are rough there, and if the septum fractures in the model, and then it will be very difficult for you to manage. So make sure you are very gentle and spend some time there, and then slowly you elevate the septum. You go anteriorly, you go posteriorly, then you go cranially. Okay, and then you reach the bony cartilaginous junction. Now, bony cartilaginous junction, sometimes it's not that easy to see. Suppose you are using an endoscope, then it is easy. But if you are using the conventional headlight, then sometimes it may not be easy to see. So, how to know? It is by the feel of the elevator. Now, when you are elevating over the cartilaginous part, the cartilage is pretty smooth, whereas the bone has undulating surfaces. And once you reach the bone, the undulating surface comes and the grating sound comes. That means you have elevated the mucoperichondrial flap. Now you have gone on to the mucoperiosteal flap. So elevation of mucoperichondrial and mucoperiosteal flap on ipsilateral side, that is the concave side. After elevating it completely, then what you do, you dislocate the cartilage from the perpendicular plate of the ethmoid and the vomer. Okay, perpendicular plate of ethmoid and vomer. And then what you do, you elevate the mucoperiosteal flap on the opposite side. So, while separating the bony cartilaginous junction, you should be very gentle so as to prevent any tear on the opposite side. So always remember, when you are doing a septal surgery, in between you just have a look into the opposite nostril to find out whether you have made any tear or not. Suppose there is a small tear, then you have to be more cautious. So, so in between you should have a look also of the opposite nostril. So then, after elevating the mucopericosteal flap on the opposite side, then you have the cartilage in your hand. Now comes the cutting technique. So cutting technique indicates what is the scoring of the cartilage. Scoring means you give incisions, parallel incisions on the cartilage. So, and suppose there is a deviation, what you do is, after giving when you give the incision, you will see the cartilage sometimes becomes straight. Okay, but what happens is, the cartilage has memory. So if you just give scoring and leave it like that, after 3 months again it will bend because of memory. So what you do, you can split the cartilage. like how we splint a forearm or arm, no, you splint the cartilage. So splitting of cartilage can be done in two ways. Either you use uh, another piece of cartilage, straight cartilage. After excising it, small bit of cartilage, you can suture it to the most what you say, the bend area, or the, that is called splinting or the batten graft. BATTEN, batten graft. So batten graft, you can use a cartilage, and then what you do, suppose this is bent here, after scoring it becomes straight, then you keep the, now can you see me? Hello?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
See, this is, can you see my hand? Can you see my
Yes,
hand?
sir.
Acha, now see, this is the bend here, and you give scoring all the way, and the cartilage becomes straight. Now you can remove this small piece of cartilage from the floor, and then you tilt the cartilage like this, and you can suture it. So this, what happens? It acts as a splint. So this is called the batten graft. BATTEN, batten graft. So instead of using a cartilage, the ideal will be to use the perpendicular plate of ethmoid. So the perpendicular plate, you know, is a very thin bone. So in order to use the perpendicular plate of ethmoid, you have to cut the ethmoid bone properly, so that and then you take the bone out, and then you make it thin using a diamond burr, and then after thinning it, you make what you say, openings on the or small holes for the suture to pass, and then you take the perpendicular plate of ethmoid and splint into the cartilage. You followed? Could you follow?
Yes,
Huh?
sir.
Acha. So this is the cutting technique. So you do scoring of the cartilage, and after scoring of the cartilage, you take the batten graft or the perpendicular plate of the ethmoid, and you keep it and suture it. So thereby what happens is the septum becomes straight. And the next is the suturing technique. So the suturing technique means, here what you do is you take a mattress suture. So here the entry point of suture should be on the convex side, and the exit point also should be on the convex side. So mattress suture you have to take, and then you slowly tighten the suture till your what you say, the septum becomes straight. So before suturing, before suturing, what you do is you score the cartilage little bit. Here you score the cartilage so that the cartilage become little flexible. And the point of scoring the cartilage is to break the fibrous strands, and then to make it more what you say, flexible. You understood, no? So that is why scoring is done. Scoring is nothing but a partial incision given on the cartilage. A partial incision given on the cartilage. Okay, so that the cartilage becomes more flexible now. Are you following it?
Yes, sir.
So then after scoring the here, when you are planning to give a mattress suture, no, you underscore the cartilage little bit, so that when you tighten the suture, no, the cartilage doesn't break or give away. So here you do little underscoring, and then you tighten the mattress suture, and you see at which point the septum is becoming straight. So this is known as the suturing technique, where you use a mattress suture. Then third is the relocation. Relocating means what? Suppose most of the cases you see the cartilage usually if you see the diagram, the cartilage sits on the maxillary crest and the palatine crest. So sometimes when the cartilage height is more, it comes out of the maxillary crest. So in this condition, what you do, that excess length of cartilage, you cut it and then you push it back into the crest. So and you push it back into the crest, and what you do is the caudal end of the septum, you suture it to the anterior maxillary spine. The caudal end of septum, you suture it to the anterior maxillary spine so that it doesn't again slip back. And even also you can suture the cartilage onto the maxillary crest also by drilling and making openings so that the cartilage remains on the maxillary crest and doesn't come out. That also you can do, but it is easier said than done. Whereas suturing to the anterior maxillary spine looks okay to me. We are doing it in most of the cases where the particularly your caudal dislocation of septum case, where the caudal end of septum is not in line with the anterior maxillary spine. So when there is a caudal dislocation also, you can just trim the caudal end little bit and make sure you bring it into the midline and suture it to the periosteum of anterior maxillary spine. So this is known as the relocating, because it was there somewhere and then you relocated the septum into the midline. So you have the cutting technique where you do a scoring, underscoring, scoring, and then in case of anterior dislocation of septum, you remove the excess cartilage and then bring it and suture it to the anterior maxillary spine. Then you have the suturing technique where you use the mattress suture, and the mattress suture, the suture entry and exit point are on the convex side, not on the concave side. And then you have the relocating technique, where particularly where the cartilage has dislocated from the maxillary crest and the palatine crest. So you bring the cartilage back and suture it to the maxillary crest if possible, or you suture it to the anterior maxillary spine. So these are the few techniques used in septoplasty. Whereas in SMR you are not bothered. So that is why the septoplasty is not an easy surgery to go to do. It's a really difficult one, and where you remove very small piece of cartilage and try to preserve maximum. That is why the revision revision septoplasty is much easier than a revision SMR. So the SMR again, the SMR now coming to the SMR part, we have discussed so much about septoplasty. The SMR is very important is to gain access to intranasal operation like transsphenoidal hypophyseectomy. Here what you do is you do a SMR, you remove the cartilage, then after removing the cartilage in a septum, you remove the bony septum, and then you reach the rostrum of sphenoid, and from there the dissection goes on, and after removing the rostrum you enter the sphenoid sinus, and then posterior wall of sphenoid sinus you have the pituitary. So this is the approach. And also if you want cartilage graft, also you can harvest and use the cartilage graft. Particularly suppose the graft is required in ear surgery, and where you are not getting adequate graft from the pinna, you can use. Contraindication, acute upper respiratory tract infection, age below 17 years. These are bleeding disorder, diabetes, they are common for both. So I have already told you about the incision. So the advantage of using a free incision is the incision is made over the thick skin, making elevation of flap easy and with minimal risk of tearing the flap. So, but the septal surgery, you have to be really patient, and you have to have, you should not use undue force or show your strength. Even though the flap may not tear, but if you fracture the septum, then everything goes waste. So you can see this is the hemitransfixation incision and this is the Killian incision. So the hemitransfixation incision gives good access to the whole septum, and if need arises, rhinoplasty can be done by extending the same incision to a full transfixation. So here, hemitransfixation incision or the Freer's incision. So this already we have discussed, surgery part. Antibiotics and analgesics pack usually then what happens ki once you finish the surgery now, then you suture, then what the incision you gave, you suture the incision with a absorbable suture material, like either you use a catgut, chromic catgut, or you can also use Vicryl, and then you pack the nose. Nowadays we are using aerosol pack, because what happens, the packing should, the pressure should be equal on both the sides, and this what it does, it promotes again attachment of the mucoperichondrial flap to the septum. So this is why we use a aerosol pack. Ideally 24 to 72 hours is more than enough. uh, Sorry, 48 to 72 hours. Forcible blowing of nose, vigorous exercise training are to be avoided. You can use liquid paraffin drop for lubrication to loosen crust and clots if they are there. Complication, primary hemorrhage can be controlled by adrenaline pack, bleeding from bone. Particularly, I told you the greater palatine artery may bleed from the floor. You can use bone wax, bone hemostat. You can also take a bipolar cautery and cauterize it, or you can drill it with a diamond burr. Mucoperichondrial flap is torn on both sides at identical spot, means septal perforation can result. So what you do here is, if you are doing a SMR and you have perforation on both the side, what you do is you put back the septal cartilage, you straighten out the cartilage, remodel the cartilage, and put it back. So that can prevent development of septal perforation. And injury to turbinates along with septal flap can lead to synechia. So we have to be very careful. So perforation, small to medium sized perforation can be closed using grafts or flap. Now perforation which are symptomatic, you have to go for closure, and you can use a graft at temporalis fascia and mucosal or upper lip flap. You can use, or a pedicle flap you can use, and fascia lata, turbinate also you can harvest some flap mucosa from the turbinate. You can also use pinna, that is the mucoperichondrial flap from the pinna. Okay, graft material. And also you can use flap, that is a mucosal flap, maybe up from the upper lip, that is the pedicle flap, or you can use a labial, septal, or even buccal flap. So large perforation requires elastic obturator or button, and CSF rhinorrhea we have not encountered any case. These are the common complications. So this you can see the, I'll go through, run through the pictures. You can see this is the anterior tunnel approach, this is the inferior tunnel approach. So particularly when you are having a septal spur now, so you go above the spur, you come below the spur, and you have to elevate the flap, and then this is the pointed spur. So you elevate here, above the spur, you elevate below the spur. This junction you do a sharp dissection, thereby preventing tear to the mucosa. So this is a inferior tunnel. You create a inferior tunnel, and this whole thing is the anterior tunnel. Any doubt? Any doubt? Anyone having any doubt? Okay. So thank you. We'll meet next week again.